Hello, I'm Michael Ward, and this is HealthWatch. Today, we're talking with John Mayle, the owner of Reality RX, and Dr. Casey Halpern, Associate Professor of Neurosurgery at Penn Medicine, about the use of focused ultrasound for the treatment of essential tremor. Can you both briefly introduce yourselves?
Sure. I'm Casey Halpern. I'm Chief of Stereotactic and Functional Neurosurgery and an Associate Professor of Neurosurgery here at the University of Pennsylvania.
I'm Jonathan Mayle. I'm CEO of Reality RX. I've been doing this medical marketing biz since the 80s. For a while, I was hoping to be a painter and turned sculptor, and I did that until my mid-30s. I had studios in Germany on the Danube and then in New York on the East Village. In 2009, I left the large agency life to open up Reality RX with my partner, Robert Guzewski. And here I am today.
And John, at what age did you first notice tremor?
It started when I was fairly young, like 28 years old. And I noticed my mother had it, and I didn't know what it was. Mine was not particularly bad at 28. I was doing very fine artwork and graphic design.
At what age did it become worse where you thought you needed to do something about it?
At 60, it started to get much worse. My kids at the dinner table noticed it and said, "Dad, what's wrong with your hands?" And it just accelerated from there, and I could no longer really do artwork.
And so, John, what did you do about it at that time?
First stop was my HCP, was an old guy, and he was a good guy. He basically told me there was nothing I could do about it. And I said, that's hard to believe. He did recommend some medicines like for my heart to slow my blood pressure, but I almost fainted on
the beta blocker or something?
Yeah, the beta blockers. And eventually I got to gabapentin, which sort of worked, but it also could put me to sleep. So I did further research, and I found that there is a procedure. And I said, man, I got to check into this. I called multiple facilities, but the Mayo Clinic would accept Medicare and my gap. So I arranged a trip there. I was there 3 days. They were very thorough. This was March 2020, right before COVID.
And what did they tell you there?
They gave me every kind of test, CT scans, MRI scans, everything. And I saw 3 neurosurgeons. I saw a psychiatrist, everything. When the report came out a month later, they informed me that they could not do the procedure I wanted because my skull was too thick. And so I kind of gave up because I was not going to let them, what's it called when they drill in your head, doctor?
That's a pacemaker-like procedure called deep brain stimulation.
Yeah, deep brain stimulation, yes.
That's been around for a long time.
Yeah, no, that was the Mayo Clinic way.
Yes.
And so, John, how did you end up becoming a patient of Dr. Halpern?
Okay, that was actually a short journey. It may sound long, but it was 3 years later. I started seeing another neurologist at the behest of my new doctor, who I love, with MD VIP, Dr. Kirikov, and he suggested I go see this woman. And then she gave me a few recommendations, one of which was to call Penn Medicine and Dr. Halpern. And your good people got me in October, and we talked. And I sent all my papers from Mayo Clinic over here.
Right.
And when we got in there, I said, I know my skull's too. He said, no, I think I can do something with that.
John and I met at Pennsylvania Hospital in the Spruce building. I remember it well in my clinic where I see patients with tremor and Parkinson's. I would say about 2/3 of those patients see me for consideration of focused ultrasound, the procedure that John had and was being evaluated for. Yes, a lot of patients do get deep brain stimulation. We do a lot of these procedures. Most of my essential tremor patients get focused ultrasound. Some of my Parkinson's patients get focused ultrasound, but the opposite is true for deep brain stimulation. The majority of Parkinson's patients get deep brain stimulation. Minority get focused ultrasound, and perhaps that will change over time. When we first met, John had a pretty thorough standard workup performed by my great colleagues at Mayo Clinic. appropriate MRI scan, overall fairly normal for his age, cognitive function that was above normal, of course, but certainly safe to have the procedure. But there was this one hook that his SDR, the skull density ratio, was a little lower than what's considered ideal. And that was pretty much the focus of our conversation. Is this a feasible treatment when the skull density is not optimal?
Do you mind talking for a minute, just in layman's terms, about the focus ultrasound and what it is and how it works?
I liken focused ultrasound to that little trick we probably all used to play when we were kids, sort of sitting in the backyard of our homes or on the field with a magnifying glass. And we would take the sun's rays and shine the rays through the magnifying glass. And if, we had a sibling with us or a friend, maybe we'd ask to borrow their hand for a moment. We'd burn their hand. My older sister did that to me. I love her dearly, but I would only do it to the dead leaves on the ground. But you can remember burning a hole through these leaves. And it was actually, to this day, something I still marvel about. You can cause a fire, my gosh. So, but it turns out in a much more controlled setting, using high-intensity ultrasound technology with an MRI scan in real time, you can do a very similar type of treatment. Now, ultrasound technology is typically used to get pictures, maybe of a kidney stone or of a baby in the uterus. But in patients with tremor, we can use it at high intensities to actually heat, much like we used to do to a leaf in the field. But with an MRI scan and using the heat map that the MRI scan allows for, we can actually detect where that heating is happening and deliver it in a very specific, small, precise location, which is how we treat patients with tremor.
So, Dr. Halpern, can you tell us a little bit, what is the MRI heat map? How does it work?
Yeah, this is an important technology that makes this treatment so precise and safe. We typically think of MRI as a way to get a picture of the brain. And in this case, we certainly use the MRI to get pictures serially during the procedure. But we also use the MRI as a heat map. The technical term is MRI thermometry, which is basically a thermometer that the brain allows us to sample in real time during the treatment what the temperature is. And we know the safe range and the intended range that the temperature needs to reach in order to safely treat and control tremor. That type of heat map also ensures that if a patient comes in for the treatment, that we know that the treatment will be sufficient to control their tremor, not just in the short term, but in the long term.
This procedure, is it MRG FUS?
Yes, MRI guided focused ultrasound.
And how long have you been performing this procedure?
I went to Stanford as faculty after my training here at Penn in 2014. My experience there started pretty much on arrival. Stanford was part of an early clinical trial, was one of the first sites in America to offer focused ultrasound for patients with tremor and then with Parkinson's. So this was one of the early phase studies that I got to play a lead neurosurgical role in. And started in 2014. Once the trial got approved, we also then transitioned our research program where we would take care of patients as part of a clinical trial at Stanford to the actual clinical program where we would get insurance to cover the treatment and move the actual treatment to the hospital setting versus more of a research facility.
And what patients can benefit most from it?
Patients with essential tremor seem to benefit the most, and that's patients that have also tried at least a couple medications, propranolol, which is a beta blocker, primidone, which is actually a barbiturate, a kind of medication historically that would be used to control seizures. Both medications seem to sort of mitigate the energy in the brain that leads to tremor. I oversimplify it, but I consider them both to be downers. And that's why a most common side effect of both of these medications, gabapentin included, is that they can make you sleepy.
and a little depressed, especially the middle one you said.
Yes.
Stopped that after a month.
Yeah, common side effect. And, if we see people with essential tremor that also have uncontrolled depression, or at least a significant history of depression, we often don't try primidone for that reason.
Let me also note that my good HCP, Dr. Walhai, recommended alcohol.
Yeah.
But one of the funny things was he recommended I keep a flask of whiskey in the drawer by my desk at work.
I'll let your family doctor make those kinds of recommendations. But if alcohol helps the tremor, or at least helped it at one point, we consider that almost a diagnostic criterion for essential tremor.
And Dr. Halpern, what are the advantages for focused ultrasound versus some of the other options you mentioned? And I don't know how many other options there are, but
yeah, the most common alternative is deep brain stimulation, which is a pacemaker type therapy. Originally was a pacemaker invented by my esteemed colleague Aline Benabid in France in the late 80s. Started for tremor and then went to Parkinson's. Really took a pacemaker that was made by a company called Medtronic and used a wire that was appropriate for brain stimulation, and they found really fabulous initial results. And then when focused ultrasound got FDA approved in 2016, we've seen a bit of a trend of patients opting for focused ultrasound over deep brain stimulation. Essential tremor is a very common problem, arguably the most common neurological condition for patients over the age of 75. The beauty of deep brain stimulation, however, compared to ultrasound, is that it's reversible. With focused ultrasound, because we have the heat map and MRI, and there's no incision, the safety of it and the precision of it is better than how we used to do ablations. But the fear of ablation still exists. And so for that reason, there are patients that still opt for deep brain stimulation, recognizing, however, that it is still invasive and has a different risk profile because it requires a medical device to be implanted.
That's what the Mayo Clinic recommended for me. And I didn't want to do it just because of that. I didn't like the idea of 2 holes being drilled in my head.
Yeah.
Even my doctor recommended the alcohol, said anytime you open up body, you could have problems.
I'd say the chance of a major complication is under 1%. But, we do about 150 deep brain stimulation surgeries a year at Penn. So we do see problems occasionally. Luckily, they're largely recoverable. They're small and they're less common in patients with essential tremor because the brain is structurally normal. Whereas in Parkinson's patients, the brain does atrophy more because it's a neurodegenerative disease. So their brains are a little bit more susceptible to these problems. When the skull density is not favorable, there's probably a higher chance of not being as satisfied with the treatment, knowing that if you're not satisfied, you can always move forward with deep brain stimulation in the future.
Yeah, you said that if it doesn't work out the way we want.
Exactly.
But you seem confident, and in my mind, you succeeded.
Yeah, I think so too. And your skull density, while not optimal, it wasn't out of the question.
0.25.
Correct. Yeah. And there's other alternatives as well. For somebody who could not get deep brain stimulation, for example, you could do radiosurgery using gamma knife or cyberknife technology, which is basically radiation. The problem with that therapy, and the reason it's sort of our third line option, is that it doesn't have any immediate effect. You pretty much have to wait 5 or 6 months to see what the effect is.
Really?
And so in some ways, you're kind of crossing your fingers that it's positive. Now, I have colleagues around the world that offer that as their first line option. They've done thousands of them and they swear by it. The problem is to get to that level of experience, there's always a little bit of a learning curve. And so there's some reluctance to using it. But there are some centers around the world that use it. So they think very highly of it. But in my experience, because we have focused ultrasound, it was never a technology that I really needed to develop as much expertise.
Can you talk about the day of the procedure?
So we got up at 5, came over here at 6, got all signed in. And then I think it was around 7:30, I went up to the, what is the room where they have a lot of patients sitting in beds?
It's the pre-op holding.
Pre-op holding. I got in the gown. So I was lying in bed and all the technicians and nurses were amazing. And then the good doctor walked in and you were like singing a song.
That's my favorite day of the week.
Yes. I was like amazed. This guy has such great, what do you call it? Bedside manner? I guess I was in a bed, so that's bedside manner. I've done a lot of things with neurosurgeons because of my business, marketing surgical products who you know very well. And they are described as being only focused on the issue at hand and somewhat curmudgeon-y. You are the exception.
Thanks, Jim.
Yes. And then after you told me what was going to happen, which I kind of knew because you told me before, but you told me a second time, they shaved my head and bolted me in. So that's the only time that I had any kind of, sedative or whatever. They put me out for the screws in the side of the head. And once they put the ring on me, which I guess is to make sure I don't move.
That's right.
Inside the MRI. And so then they took me into the MRI area, and there were a lot of people. It was a hub of activity. And then you came in and asked how I was. And so from there, you started putting me in the tube, in, back out, in, back out. And I guess my assumption was that to make sure you were targeting the exact space. So that actually took like an hour of attempts.
Yep.
And then when you were ready, I was brought back out and you had me do one of those drawing tests where I had to draw within a circle. And at first I found I was all over the place.
Yeah.
And so then you told me, or the head technician told me, you're now going to start doing this. And you were in the back room where you were viewing the monitors.
Control room.
Can you describe from your point of view what was going on?
Yeah, that was a great summary. And, it's my favorite day of the week doing focus ultrasound. We can help patients in ways like we helped you without making an incision. It's modern day surgery, even though it's not really surgery. There's no incision, obviously, but the procedure around it still has the same safeguards. That's why you met with Denise ahead of time and she reviewed your medical history and just got everything dialed in for you to make sure you were safe. She's a wonderful nurse practitioner, arguably the best clinician I've ever worked with. And I'm lucky to have her as my partner in crime. On the day of the procedure, you met with a different set of team members, also fantastic.
Mm-hmm.
Probably my RNFA, a nurse as well, named Jean, a fantastic proceduralist. I call him Spider-Man, helps put the halo on. And my fellow, usually Armani.
What is the name of that? It couldn't be the halo.
Some people call it a halo. The technical term is a frame, head frame.
Okay.
Yeah. But the halo is a term that comes from spine trauma. When people injure their necks, they are put into a halo to keep their neck. It's kind of like an external cast for the neck.
Wow.
And the halo device is similar to a head frame. But I don't believe it's MRI compatible. That's why we have a specific head frame that we can bring into the MRI scanner. So the beginning of the procedure is giving me some IV sedation. That's done under the guidance of an anesthesiologist and a nurse. Once you're asleep, we do the head shave and the head frame, all under local anesthetic. So there's no significant sharp pain.
No.
Although when you wake up, it could feel tense, like a tight belt strapped around your forehead. Probably how it felt. Bring you into the MRI scanner, and while you're waking up from anesthesia, we're doing the registration part of the procedure, which takes about an hour. As you're waking up, we're getting pictures and registering, making sure that we can identify where the tremor cells are in the brain using the MRI scan that you got ahead of time. Once you're awake, we then test your tremor. We give you opportunity to do some handwriting with spirals, which is kind of a standard way to assess tremor. It's not always the best way to assess it, but we do it in every patient. So it really allows us sort of to understand kind of a normalized effect of what we're doing, since we do it in everybody. And once the anesthesia has worn off and our registration is complete, we have our baseline and you're awake, we start the treatment. And that's, usually about 30 to 60 minutes of a serial amount of treatments, probably 3 or 4 treatments with a couple of verifications in the beginning. And that's where the art of treating somebody with their skull density not being optimal comes in. And clearly was successful for you.
Can you talk about those treatments, like how you ramp those up or how it works?
Another part of this technology that makes it so safe is that you can deliver a treatment that's temporary. and a little bit of heating delivered to a small spot of the brain that, let's say, causes a side effect. We know that's not going to be permanent, might last a couple of minutes. The most common side effect we see is tingling in the fingertips. That tells us, okay, maybe we need to make a little adjustment to where we're delivering this treatment. We make a millimeter type of adjustment, very, very small adjustment, and then we do it again. And if we see that the side effect goes away, we're more confident that we can deliver something that's safe, especially if we see some temporary relief in your tremor. So those are the verification treatments that we deliver. It's usually 1 to 3 of those until we see safety. And once we've confirmed safety, then we deliver the real treatment. And that's when the temperature can get to 54, 55, 56 degrees, which we know to lead to a permanent effect. We don't want to have anything permanent done until we know that there's not going to be a side effect.
Did you feel those?
Yeah, I could feel everything. It felt like heat in the center of my brain. Did you increase it some in the second round? Yeah.
The two things, we're trying to standardize this for other centers so that when they meet patients like you, like the Mayo Clinic scenario, they feel more comfortable offering the treatment. The goal is to deliver enough energy such that we can control tremor. And there's 2 ways to do that. One is to get the temperature high enough or deliver the therapy for long enough. And that's where, if you remember, I said to you, we're going to deliver 1 more. And then I retracted that idea because I realized one of the treatments, while we didn't get to the temperature we like, let's say 55 degrees, I believe we got to about 52 degrees, but we delivered that for about 20 seconds. So we knew that that was long enough to induce a permanent result. So it's not just about the peak of the temperature that we get, but it's the amount of time that we spend at a certain temperature. And so in your case, even though we didn't get to the peak temperature that we would have liked in that first or second treatment, we delivered it for long enough that it did have a permanent effect, which we could see on the MRI scan.
Beautiful. And then the second time, it was even more intense.
Yeah.
And I think then I asked, can I be a cowboy and put something in my mouth to like tap on?
Yeah. Once we've established that we're in a part of the brain that's safe, we do let patients get a little painkiller or anti-anxiety type of IV treatment to take the edge off. Because you're right, at high intensities and when the skull density is not optimal, we have to deliver treatment for a longer period of time. Typically it's 10 or 15 seconds. But in your case, it may have been 25, 30 seconds. And that can be a long enough period of time where feeling uncomfortable, it feels like a year.
It does. Well, you guys were great. Everybody was good. I was going through with it hell or high water.
Yes.
And because we saw the results.
That's right.
It was, the first time with the higher intensity treatment.
Yes.
You saw the results and you said, we're on the right track.
One thing we've learned is when we see that result, it's great to get excited. The patient also feels excited and motivated. The mistake is to stop. Because if you haven't done it enough times and gotten to a sufficient temperature or delivered it for a long enough period of time, that wonderful result that you're enjoying for that brief moment will go away. And in about a month, you're going to come back for more treatment. And we try to prevent that to the best.
Yeah, that's probably wise. No, I'm still good.
So I always remind patients, although another treatment might seem a little unnecessary and you really don't want to do it, you're still going home that day.
Yeah.
So give me one more, 20-second period of time and I can make sure to the best of my ability.
What made you decide not to do it the fourth?
I had not realized how much time we had delivered those 3 treatments. And once I realized that and had that calculation done, it was clear that you had more than enough. Then the artist know when to stop.
Yeah.
It's complicated. It's kind of like walking a tightrope. You have to deliver enough, but not too much.
So, John, let me ask you, how would you rate the procedure, your overall experience?
The tremor's gone, so I have to give it a 10. I get a little concerned about the side effects, which are not significant, and they're getting better. But I can still, in the center of my brain, feel a little something. And then, like I said, when I get tired, my left foot drags. I call it my Igor walk.
And Dr. Halpern, were those kind of things usually go away over time?
Yes. So these are very common side effects. First of all, the discomfort or the heating sensation you probably feel probably is not from the center of the brain. It's probably from around the scalp, and it may actually be related to that head frame. It could also be related to the intensity that we had to deliver the treatment at, which is higher than the average because of your thick skull. Your mother was right. You do have a hard head, but it wasn't too hard. But we're still able to obviously do the treatment, but it required a higher intensity.
Yeah.
And that might be why you still feel a little bit of that sensation.
Yeah, it's going away. Where it is today, I feel like you're right in there.
Yeah, and that's very close to where those little pins were, by the way. And then the weakness that you feel, or the little Eeyore walk when you're tired, with a little bit of time, a little bit of physical therapy, that resolves.
Yeah.
What that is due to is inflammation. So whenever you do an ablation in the brain, you're destroying 1 millimeter or 2 millimeters of tissue. It's a very small amount. So just to be clear, the treatment here is very focal. However, a day after the procedure, inflammation can develop, and that's what causes side effects.
And you gave me like 6 steroid tablets today.
That's right, because the first week after the procedure is when the inflammation is the worst. And then it tends to linger. And surprisingly, in the brain, it can linger for much longer than people realize.
Yeah.
Most side effects within a month are gone or extremely mild. The large majority are gone at 3 months, and almost all of them are gone at 6 months. But you can see some of these things linger for longer than you suspect. And the good news is they're usually quite mild.
I got one last question for Dr. Halpern. It's just a big picture question about, in your opinion, where do you think focused ultrasound is going? What's the potential for the future?
Yeah, I think this is only the beginning. We have approval now for Parkinson's tremor and Parkinson's disease, where patients suffer from other types of movement issues. We see great results. I had a Parkinson's patient last week. Unfortunately, insurance didn't cover his treatment, so he actually had to self-pay. Penn makes this feasible for patients. It's expensive, but it's not as expensive as you might expect. And this lovely patient, the day after the procedure, this is an 82-year-old gentleman, he didn't even look like he had Parkinson's anymore. It was really remarkable.
Wow.
So kind of like you've seen this relief. Now in a Parkinson's patient, they tend to have diffuse symptoms on both sides of their body. He was lucky that he was prominently bothered on one side of his body. That's why he was a good patient for this treatment. Plus being 82, he wasn't a great candidate for deep brain stimulation. I don't think it's going to stop there, quite honestly. I see patients with obsessive compulsive disorder benefiting from this treatment. And my research is really focused on dangerous urges, things that you see like with addiction and eating disorders, OCD as well.
Wow.
And we're identifying small spots in the brain in our research that seem to light up during these vulnerable moments. And so focused ultrasound would lend itself very nicely to these types of treatments.
So you're going to move around, because I thought of this as just being on the thalamus, which is the target for the essential tremor.
Yep.
But you're saying you're looking into other areas of the brain.
Yeah, my research is mostly focused on a part of the brain called the nucleus accumbens, which is directly connected to the thalamus, but it is a different region. But it's similar in size, similar in location. And so it's likely a very amenable target for ultrasound therapy. The ultrasound is really good at treating, like you said, the center of the brain. Mm-hmm. And the thalamus is one structure in the center, and there's luckily others. And one of them is involved in reward and sort of these dangerous urges that really plague our society. And so I envision in the next 5 to 10 years, a new treatment coming online for conditions that are even more common than essential tremor.
Sports betting.
Pathologic gambling is an area that I'm really interested in. Patients with Parkinson's have it. It's a real big problem. And so, yeah.
Would there ever be a chance that you could use this procedure so it was non-invasive on a tumor?
We've already started to use it for small tumors located in the center of the brain. And the most common sort of perfect example of that is a tumor called hypothalamic hamartoma. These are fairly common, very well-known tumors. They're very well circumscribed, like a tiny little pea in the center of your brain. And the problem with these tumors, well, there's 2 big problems. One, they cause seizures, and they cause a very classic sort of concerning seizure called gelastic seizures, where often in children, they can't stop laughing. They have these uncontrollable laughs, and it's embarrassing for them. So now they also have the typical seizure where they can convulse and they lose consciousness. The second problem with hypothalamic hamartomas is that it's very hard to treat them with medication, and so you often need to use surgery. But because they're in the center of the brain and they're really small, the surgery is very high risk and often failed and aborted during the procedure if the tumor can't be removed safely. And so ultrasound becomes a wonderful option. We've actually done it successfully 3 times. That's probably an area over the next 5 years that we see getting a lot more.
So, Dr. Halpern, if we were talking to a friend of ours or someone about how to get a hold of you,
what I would say is the easiest way to get a hold of me is not in a HIPAA compliant standard way. So, if you ever reach out to me on Gmail, just know it's not a patient privacy type of mechanism. But No Tremor Left Behind at gmail.com I created to help with access. Of course, don't share too much personal information there, but I can see that email and refer it to my team in the clinic to get patients in. A more standard way is to call our office, the Department of Neurosurgery at Pennsylvania Hospital, phone number 215-829-6700, and ask to have an appointment with me. You can also reach out to the Penn Access Center. The problem there is that they don't have direct access to my calendar, and often that can lead to some delays and confusion. So I would always recommend reaching out to us directly. My Penn email, I get hundreds of emails a day, and I do need to sleep a few hours at night, so I don't get to all of my emails. So I never recommend my Penn email for access. But the Gmail, surprisingly, I only get about 20 or 30 emails there a day, and so it's much easier to navigate. And maybe that will grow thanks to your podcast.
I love that. No Tremor Left Behind. And that's what this podcast is going to be called.
Well, thanks, John Mayle. Thanks, Dr. Halpern.
Pleasure.
Appreciate your time.
Thanks for having me.
Yes.
This is a very special place. It's the Historic Library of Pennsylvania Hospital. And I'll just mention, while Benjamin Franklin is typically thanked as the founder of this hospital, as he was, Benjamin Rush is considered the modern day father of American psychiatry. His son was a patient here when he was a practicing physician here. And he made the world realize that while his son was temporarily in the insane asylum in the basement of this hospital, he wasn't insane or mad. He was just sick. And really, with treatments that we don't use today, but maybe compassion, he was able to bring his son out from the basement of Pennsylvania Hospital to the regular ward and then actually discharge him from the hospital. So I mention that because we're trying to do brain treatments here, obviously very different ways, but it's a wonderful history, sort of kind of a platform to work from for how we treat patients today.
That's awesome. Thank you.
It's such a pleasure.